Did you know FDA-approved Vyvgart, efgartigimod alpha-FCAB, is available for your adult patients? Visit vyvgarthcp.com to see the data and explore how it works. Vyvgart is a registered trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone, and thanks for tuning in to this week's Neurology podcast. We have a special podcast for everyone listening out there today. I had the pleasure of interviewing my colleague, Seemant Chaturvedi, who's the Director of the Stroke Division and Vice Chair for Strategic Operations at the University of Maryland, Department of Neurology. And Seemant is going to be talking with us about his experience from attending this year's European Stroke Organization Conference, which was held May 24th through the 26th in Munich, Germany. For many of our listeners, you may be familiar with stroke conferences here in the United States and North America, but this particular conference by the European Stroke Organization has become quite an event, a place to learn about new science, new trial results, growing in prominence over the last few years. And true to form, there was an exciting lineup of new trials in the field of stroke and cerebrovascular disease that were presented at this year's conference, and we wanted to share some highlights from those with you all listening out there today. So first and foremost, Seemant, thanks for joining us for the Neurology podcast.
Yeah, my pleasure, Andy.
So we can't cover it all. There really was a smorgasbord of new science presented at the conference, but I think that we're going to focus on just a few pivotal trials that we're presenting, starting with one in the field of stroke prevention. This is something that should be relevant for all of us, all of our listeners out there who care for patients who have had stroke and who are at risk for having strokes in the future. And the trial I think that we're going to get started with is the Arcadia trial. This is something that many of us were enrolling in the United States, and so we're eager to learn more about this trial at this year's ESOC event. So, Seemant, what can you tell us from what you heard about the Arcadia trial at ESOC?
The Arcadia trial was, I think, a long-awaited trial because there were two previous studies which looked at the concept of ESIS, or embolic stroke of unknown source. And it was hoped in the past that the direct oral anticoagulants, or DOACs, could be useful for patients with an ESIS type of stroke. Unfortunately, two previous trials have been negative, and there was the Navigate ESIS trial looking at rivaroxaban, and then the Respect ESIS trial looking at dabigatran. And both of those failed to show any definite benefit of the direct oral anticoagulant for patients with ESIS type of stroke. Arcadia added a new wrinkle, however, in that it required all the enrolled participants to have evidence of so-called atrial cardiopathy. And this was felt to be disease of the left atrium manifest by either a certain P-wave abnormality on the ECG, or patients could have elevated NT-BNP levels in the blood, or they could have an enlarged left atrium judged by the left atrial index. And so the concept is that if patients have problems with the left atrium or dysfunction, even in the absence of overt atrial fibrillation, they could potentially benefit from anticoagulation. And so Arcadia tested apixaban versus aspirin in these types of patients. And the study was halted prematurely after 1,015 patients had been enrolled, and it was stopped by the Data Monitoring Committee for futility. And at that time, patients had 1.8 years of follow-up, and very uncannily, both groups had the exact same number of recurrent strokes. The apixaban group had 40 recurrent strokes and 40 in the aspirin group. So overall, the annual rate for recurrent strokes was 4.4% in both groups. And so this showed no definite benefit of apixaban in this group of patients with an embolic stroke of unknown source plus evidence of atrial cardiopathy.
This result definitely made its way through the stroke community. I think many were hopeful that we would define another group of patients that we perhaps had a more alternative treatment for than standard antiplatelet therapy, but did not turn out to be so with this hypothesis of atrial cardiopathy and anticoagulation. Sort of thinking about what we've learned from the trial, and I know that we're still waiting on the full data to be published and presented. I know they're doing a number of additional analyses, the level of the trial. Where do you think we go from here, Seemant? Were there any sort of limitations in this trial population that affect our understanding of the trial, or do you think it pretty much answers the question in toto?
In the stroke community, there's been a lot of sort of discussion about whether we should abandon the concept of ESIS because it's so heterogeneous. And maybe from the research standpoint, we should focus more on specific entities and drill down even more on specific entities, and that ESIS may be too big of a grab bag because patients with ESIS, they could have paroxysmal AFib, they could have clots in the aorta, they could have non-stenotic plaques in the carotids or perhaps in the intracranial circulation, and some may have coagulation abnormalities. And so maybe it's erroneous to think that one antithrombotic agent can address all of these. And so there's been some discussion about whether we should focus more on specific entities like non-stenotic carotid plaques or other conditions. There was also a discussion about whether all the biomarkers which were chosen in Arcadia, whether those are all really equal. And because the majority of patients qualified on the basis of the ECG or the BNP levels. And maybe the thresholds which were selected were not adequate to identify a high risk enough population to potentially benefit from anticoagulation. And maybe if we focus more specifically on patients with severely dilated left atrium, maybe those patients could have some potential benefit, as some other sub-studies have shown. And then the other, I think, main conclusion is that we should probably keep our eye on the ball for overt atrial fibrillation, because it seems that this so-called atrial cardiopathy may not be a high enough risk condition, and we should focus more on overt atrial fibrillation, because we know from the public health standpoint there's a long way to go in terms of improving rates of anticoagulation and treatments of patients with overt AF.
That's a good segue to talk about another trial that was presented at this year's ESOC event, and that is a trial that has been published, the early versus later anticoagulation for stroke with atrial fibrillation trial or study, or the Elan study. And so this trial, I believe the results have been published in the New England Journal of Medicine, coincident with the conference on May 24th, 2023. And Seemant. So this trial, just kind of for our audience, was looking to try to better identify the timing of resuming anticoagulation in patients who have been admitted with stroke and who have atrial fibrillation. And so this is a question we all wrestle with when we admit patients with stroke to the hospital, and many of us use sort of observational experience or our own expert opinion to define this timing, some other patient-related factors. But what did this study show us, and how does it help inform this kind of regular question that we encounter in stroke patients?
This study, I think, is very practical, and it's very relevant to the daily practice of many neurologists who take care of patients in the hospital, because it's a very common reason for consultation, which is the timing of anticoagulation for AFib with a stroke. Andy, in the past, you may recall, in a previous podcast, we discussed the 1-3-6-12 rubric, and that's a tool that I've used in the last several years, which says that if it's a TIA, start the anticoagulation after 1 day. If it's a mild stroke, 3 days, a moderate stroke, 6 days, and for a severe stroke, reevaluate and wait at least 12 days. And so the Elan trial was sort of using that as the comparator group, but saying that can we sort of nudge the initiation of the anticoagulation a little bit earlier. And so in the early group, the target was to start the direct oral anticoagulant within 48 hours for a mild or moderate stroke, and to start it on day 6 or 7 for a more severe stroke. The caveat is that their definition of mild or moderate was more of a clinical and imaging-based definition compared to the 1-3-6-12 rule, which in the past had relied primarily on the NIH stroke scale. And so what the authors found is that the early initiation did slightly better. And if you look at the recurrent events, they were about 3% with the early initiation compared to 4.1% with the later initiation. Not a huge absolute difference, but in terms of the primary endpoint, which included ischemic stroke, hemorrhagic stroke, systemic embolism, major bleeds, there was a slight reduction in events in the early initiation group. And many clinicians in the past have had concerns about transforming the ischemic stroke into a hemorrhage by the early initiation of anticoagulants. But this study showed that it was very rare, and that the hemorrhagic transformation was only about 0.2% in both groups. And so I think that's very reassuring, and that's, I think, likely related to the fact that the DOACs have much less brain hemorrhage in general. But in this study, the rate of hemorrhagic transformation was very low. One caveat, though, is that at the time of randomization, the NIH stroke scale was pretty low in both groups. It was around 3. And so this was really a pretty mild stroke population. And so I think if you have a patient who you're seeing in the hospital with a moderate or severe deficit, it could be prudent to still wait either 6 days or 12 days to begin anticoagulation. But I think the Elan trial shows that if the patients have mild to moderate deficits, and I would say if the NIH score is like less than 8, then these patients appear relatively safe for early initiation of anticoagulants.
This study I think is really additive for all the reasons you pointed out. This is a hard entity to study because it is so dynamic. You're looking at multiple different time points, multiple different ways to estimate the severity of a stroke, the risk of bleeding. But at least this gives us some additional rubric beyond the thumb rule you mentioned earlier, which I do recall from our prior podcast and something I think that I grew up using and being taught as well. So I'm excited to be able to apply these new data for my patients to teach our residents and students the same and feel a little bit more comfortable in starting anticoagulation sooner, particularly with our direct-acting oral anticoagulants in patients with at least minor or moderate strokes or infarct size. So really exciting trial. I encourage listeners to check it out in the full manuscript in New England Journal of Medicine. As we're moving along, we want to cover a couple of additional studies. And since we're talking about risk of intracerebral hemorrhage, we might as well talk about 2 pivotal trials in patients presenting with primary intracerebral hemorrhage. One trial was the INTERACT 3 trial, or the third intensive care bundle with blood pressure reduction in acute cerebral hemorrhage trial. Seemant, what can you tell us about this most recent ICH trial?
This trial was looking at a multifaceted intervention for patients with intracerebral hemorrhage. The main intervention was blood pressure lowering and trying to get the systolic below 140 millimeters. But also the research study included attention to glucose and also prevention of fever and trying to keep the temperature less than 37.5. And also for patients who were on anticoagulants, rapid correction of warfarin and trying to get the INR corrected within 1 hour. As it turned out, very few patients were enrolled with an anticoagulant-related hemorrhage. And so it was really primarily a study of patients with hypertensive hemorrhage. And what the authors found is that with the intensive blood pressure reduction, it was about 7 millimeters lower at 1 hour and 4 millimeters lower at 24 hours. And they found that overall there was improved functional outcome compared to usual care. And the number needed to treat was 35 in patients who received the intensive care bundle. They also had lower mortality of 14% versus 17%. And they also reported benefits in quality of life. And so overall, this population, they were not patients with huge hemorrhages. The median ICH volume was 15 milliliters. But in this population, there did appear to be some modest benefits with the intensive care bundle. And also another interesting finding is that the majority of patients were enrolled from low to middle income countries. And so I think this illustrates that a lot of the elements in the care bundle can be widely applicable.
That last point's, I think, really key, Seemant. Is this something that, folks listening to this, whether they're in a comprehensive stroke center or a community hospital, if they are in a facility that does take care of patients with intracerebral hemorrhage, is this the kind of bundle or care package that most places could implement? It seems like that your answer would be yes, based on where the trial was conducted.
Yes, definitely. And I think, as you indicated, if you're at a primary stroke center and you have patients, say, in the medical ICU, with an ICH, all of these elements in the care bundle should be usable at your primary stroke center. And so I would recommend that primary stroke centers review this study and try to incorporate some of the practices.
Fantastic. And I should also point out that this trial has also been published in The Lancet, coincident with the European Stroke Organization Conference on May 25th, 23. So folks can check out the INTERACT 3 trial there. The second intracerebral hemorrhage trial that was presented, it was called the Enrich trial, early minimally invasive removal of ICH. This is yet another trial looking at surgical intervention in intracerebral hemorrhage, an important topic over the years. What did we learn from the Enrich trial, Seemant?
This, I think, was really a potential breakthrough. And I say potential because it hasn't been published yet, so we need to see the full publication once it is in the literature. But this looked at minimally invasive hematoma evacuation, and the evacuation was very effective. It reduced the ICH size from about 50.5 milliliters to 15 milliliters. And so they reported the median 88% reduction in ICH volume. And the authors reported a 36% reduction in the chance of a poor outcome. And this translated into a number needed to treat of 11 to achieve a modified Rankin score of 2 or less, and number needed to treat of 8 for a modified Rankin score of 3 or less. And in addition, the surgical group had a decreased 30-day mortality of 9.3% versus 18%. The benefit was mostly in lobar hemorrhages, and so they did not see any benefits in deep hypertensive hemorrhages, which is an important point. But I think this is a potential breakthrough which will change practices across North America and the world. But as I said, we need to see the full publication. But I think this could be the first demonstration that surgical intervention and surgical evacuation of a hematoma can be beneficial for patients with an acute ICH.
That is really change-making in the field. That's prior ICH surgery trials, as you pointed out, Seemant, have not been positive. And so this really would give us a foundation to look at some of these very particular ICH patients. It sounds like mostly lobar hemorrhages, easy to approach surgically. And we will look forward to the full manuscript and publication of those results to extrapolate that to practice. Finally, in our quick tour of the waterfront here from ESOC, I know that there's one trial that is near and dear to your heart, or at least the topic, which was the ECST2 trial, the second European carotid surgery trial. Seemant, tell us what we learned from this study looking at carotid stenosis surgery and what it means for practice.
Yeah, I definitely found this exciting because I've had a longstanding interest in extracranial carotid disease. And many listeners may not realize, but the original NACID publication and original ECST were published way back in 1991. And so some of our trainees weren't even born then, but it's been over 30 years. And so in ECST2, they wanted to look at the comparative benefits of revascularization versus modern medical therapy. And they included a combination of asymptomatic patients along with low to moderate risk symptomatic patients. And they reported results at 2 years. And interestingly, they found that the medical patients actually did better at 2 years with a stroke rate of 6.0 compared to 8.1% in the patients who received surgery plus medical therapy. Now, once again, the caveat is that this study hasn't been published yet, and so we'll need to see the full results once it's in the medical literature and it's been fully vetted. But I think this is a noteworthy demonstration that modern medical therapy does appear to be beneficial for patients with carotid disease and even for patients with symptomatic carotid disease. I think medical therapy can potentially reduce the stroke rate by 50 to 70% if you intensively lower LDL and if you use dual antiplatelet therapy and improve blood pressure control compared to the original studies. And I think this study also provides a lot of impetus for North American investigators to finish CREST-2. CREST-2 is looking at 70 to 99% asymptomatic stenosis, and this is an important NIH-sponsored study, and the enrollment is about 90% over, and so hopefully the ECST2 results will provide some fuel for the CREST-2 investigators to finish enrollment so that we can gain information on modern medical therapy versus revascularization for asymptomatic stenosis.
Seemant, I'll add to that plug. This is critical that we complete enrollment in the CREST-2 trial. It is, as you pointed out, predominantly being conducted in North America, and we need to make sure we complete this enrollment and have a fully powered trial to help definitively answer this question or better understand this question of how to manage patients with asymptomatic carotid stenosis. As you noted in ECS2, it was possibly underpowered because of not meeting their full enrollment sample. The patients also perhaps didn't have the same degree of carotid stenosis as we'll see in CREST-2. So this is important. If you're at a place or in a system or near a facility where they are enrolling in the CREST-2 trial, I implore you to please refer your patients with asymptomatic carotid stenosis, severe carotid stenosis, 70 to 99%, to a CREST-2 investigating site. And I suspect can reach out to Dr. Chaturvedi if you have any questions about that, who himself is on the executive committee of that trial and an expert in this category. So very exciting. I think we could continue to talk at length about the variety of trials and studies that were presented at this year's European Stroke Organization Conference, Seemant, but this is a great smattering of really pivotal trials that hopefully will form practice and that people listening to this podcast can go out and apply to their practice as well if they're caring for patients with stroke and cerebrovascular disease. So thank you so much again. I'll refer our listeners, you can check out these plenary highlights and other information about ESOC this year at their 2023 conference website. And we'll put a plug in that if you're looking for a trip to Europe, or you are in Europe or anywhere around the world, I think next year's conference is also going to be in May in, I believe, Basel, Switzerland. Seemant, if I'm not mistaken. So go ahead and set your watch for ESOC 2024 in Switzerland, and we will look forward to following up then for even more exciting science in the field of stroke. So, Seemant, any last-minute thoughts or comments?
I just wanted to congratulate the organizers of ESOC for a very stimulating conference, and it sort of covered the whole gamut from acute treatment to prevention to rehab. And the next sort of big conference on the calendar is the World Stroke Congress in Toronto in October. And so hopefully that will provide clinicians additional very practical information and more cutting-edge information to optimally help with stroke prevention and treatment.
Fantastic. There it is. So thanks again to Dr. Chaturvedi and all our listeners. We look forward to talking with you again on a future podcast. Have a great day, everyone.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.